Thank you for the kind introduction, and thank you, Akamichi and the IBC for this opportunity to present at today's global webinar. So I will be talking about a case study, which I hope will be a good discussion point for us to launch into, to looking at the complex relationship between inflammatory bowel disease and psoriasis. These are my disclosures. So the patient is a 46-year-old Caucasian lady who weighs about 72 kilograms and has had psoriasis for over 20 years with a pretty severe baseline PASI of over 20. Of note, she has no significant family history, in particular, no family history of psoriasis or inflammatory bowel disease. She's otherwise very fit and very well. She takes Ventolin for her occasional asthma, and she does suffer from occasional vaginal thrush and does take fluconazole every 2 to 3 months for mild episodes, which settle pretty quickly. She works in administration. So for the first few years of her psoriasis, she mainly treated it with a combination of topical therapy and narrowband UVB. And then her psoriasis gradually started to worsen, and there was a thought to look at whether we do commence a biologic therapy. In Australia, biologic therapy is subsidised by our government, but you do have to try back then in 2015, you had to try 3 traditional treatments and fail to improve before being funded for biologic therapy. So as a result, she tried methotrexate and then cyclosporin, and subsequently was commenced on ustekinumab. And this worked very well for her, and she had significant improvement in a chronic plaque psoriasis, and a PASI dropped down to 0.3, so pretty much nearly clear. It was noted in her clinical records that she did have a bit of mild lower back pain in 2019. However, in 2021, this really started to worsen more, involving the lower back and also the right hip. It sounded very much inflammatory in nature, with early morning stiffness and worsening upon prolonged periods of no movement, such as when she sat down for a long time or when she was standing for a long time. And it was really affecting her quality of life. She was having trouble exercising and also affecting her sleep. She tried seeing a physiotherapist, and also taking non-steroidal anti-inflammatories. And subsequently, she was referred to rheumatology, and she was noted to have mild enthesitis of her left Achilles as well, suggesting a diagnosis of psoriatic arthritis. As a result, she was switched across from ustekinumab, an IL-23 agent, to secukinumab, an IL-17 medication. And this helped very well for her axial psoriatic arthritis symptoms. And we know that certainly, although many medications, many of the biologics are indicated for psoriatic arthritis, the IL-17 groups do have a slightly higher efficacy and evidence for axial disease. Pleasingly, she had no increase in vaginal thrush, and this still occurred quite infrequently. However, her skin continued to persist in stubborn areas. Most of her skin improved, but the lower legs continued to have quite persistent plaques, as we can see here. And this obviously continued to impact her as it limited what clothing she could wear, especially over summer. She persevered with secukinumab for 10 months, but eventually the decision was made to switch across to ixekizumab. And she had a very good response to ixekizumab, with complete clearance of her skin with a PASI score of 0, and her axial disease remained quiescent. Unfortunately, when we continued on monthly ixekizumab dosing, she developed abdominal pain, diarrhea, urgency, and occasional blood in the stool. And this would occur every single month after each injection for several days, sometimes up to a week. The thoughts were potentially that this could represent inflammatory bowel disease, and so she was referred to gastroenterology. And a biopsy of the terminal ileum was suggestive of ulcerative colitis. She was commenced on sulfasalazine and cortisol suppositories, which were helpful, but she definitely was not particularly pleased with having these symptoms, and eventually it was decided that we switched across to a TNF adalimumab. And this resulted in complete resolution of these monthly bowel symptoms, and she was able to stop those medications that she was put on for her ulcerative colitis. And pleasingly, she continued to have good control of her skin with a very low PASI score, and her axial disease was also quiescent, and she did not have any symptoms of psoriatic arthritis whilst on adalimumab. So this is a summary of the case at this point. But I guess the challenges and learning points, and I guess this ties in quite well with Dr. Kiyoshi and Dr. Alex's talks, in that when we see this in a clinical setting, we have to consider, as Alex mentioned, all these comorbidities that are quite commonly seen in our psoriasis patients, and does make it quite challenging in terms of choosing the right medications that we have. I think in this case, some learning points that I took from it were that failure of one IL-17 certainly does not preclude the use of another, and this is certainly supported by quite a few reviews that have been published in the JAD. As I mentioned, with the IL-17s, there's certainly a role in psoriatic arthritis, especially with axial disease. And I guess something that we could discuss further in the next part of the webinar is, this role between IL-17 and inflammatory bowel disease, whether this case does represent an induction of inflammatory bowel disease, or whether this is more of a association that we see in psoriasis is still debatable, and there are many studies that have shown conflicting results, whether it be that these were odd occurrences of inflammatory bowel disease developing or exacerbated on IL-17. So I think certainly something that we could discuss further. Thank you very much.
Okay, thank you very much. And it was quite interesting in a case, thank you very much, Francis. And any question from Q&A or chat? Okay, one from me. So this indicates, the patient had developed IBD, like IBD by the IL-17 inhibitors, or patient have already have some basic, some and proceeding, okay, some latent or IBD, or is there any opinion, or maybe just paradoxical reaction like IL-17 inhibitors?
Yeah, no, it's a really good question. I don't think I have the answer for it. I mean, certainly there are many literature reviews looking at this association between inflammatory bowel disease and IL-17s, and there are certainly case reports of induction or exacerbation of potentially latent symptoms, as you mentioned. I thought what was interesting with this case was that when she was on secukinumab, she had no inflammatory bowel disease symptoms, and it was only when she switched across to ixekizumab that she developed inflammatory bowel disease symptoms, which were biopsy confirmed and very much consistent on histological diagnosis. So yes, I don't have an answer for your question. It's a bit unknown in terms of her case, whether she may have had mild latent symptoms that were grumbling away that were eventually triggered, or whether this is truly a IL-17 induced case.
Okay. Is there any other biomarker for that case? That is the case, like psoriasis, IBD. So is there any biomarker for?
Not that I'm aware of. I think some centers do check for fecal calprotectin, but I was looking at her notes. I don't think she ever had this tested beforehand or during her bowel symptoms, but certainly that would be interesting, and whether that's something we screen for even, but certainly not in her case, unfortunately.
Okay, thank you very much. It's we should think about it. And I probably, and also, we think IBD and many of the comorbidities around the psoriasis and the skin diseases. So one of the important point is IBD for tonight, so for today. So I really thank you very much for your talk. Okay.
Francis, actually, I have a quick question. This is Alex.
Okay,
do you
please.
know whether the patient's family has any IBD?
No, so in her case, that she had no family history of psoriasis or inflammatory bowel disease or any other autoimmune conditions. But yeah, that's definitely a very relevant question.
Thank you.
Okay, thank you.